Hi, my name is Dr. Jonathan Pindrick from Nationwide Children's Hospital and OSU Department of Neurosurgery. I want to thank you all very much for having us all here. We wish it could be in person, but given the circumstances, I think a virtual meeting hopefully will be just as good. So today I'm going to talk to you about changing paradigms in epilepsy surgery. And really focusing on the introduction of minimally invasive techniques, neuromodulation, and broader indications, which has really been an interesting trend in epilepsy surgery over the past decade or so, maybe even decade and a half, 2 decades. I'm, as a pediatric neurosurgeon who specializes in epilepsy surgery, much of what I say is going to be based upon my experience in the pediatric epilepsy population, but all of the techniques and surgical procedures are really applicable to the adult population as well. So there are no disclosures or conflicts of interest or any financial disclosures, just my irrelevant disclosures of being a Baltimore, Maryland enthusiast in terms of my sport teams and my hometown loyalty. So as just a brief outline, I'll provide a short overview of epilepsy surgery. And then I'll talk about the introduction of minimally invasive techniques for epilepsy surgery and the introduction of neuromodulation. And both of those have really resulted in broader indications for epilepsy surgery, which I'll discuss at the end. So epilepsy surgery is something which is performed in the pediatric population and the adult population. The indications are drug-resistant epilepsy or medically intractable epilepsy. In the literature, the terminology of drug-resistant epilepsy is used more formally based upon the International League Against Epilepsy, and is defined as the failure of adequate trials of two tolerated and appropriately chosen and used anti-epileptic regimens, whereas intractability or medically intractable epilepsy implies a concept of significant seizure frequency or density. The caveat to infants and toddlers for the designation or the diagnosis of drug-resistant epilepsy is that you may not actually have to wait for two sustained for adequate trials of two appropriately chosen medications if there is a concern for significant developmental regression or impairments related to the onset of intractable or refractory epilepsy. And so intervention may be warranted earlier in infants and toddlers as opposed to adults, just based upon the significant impact of their intractable seizures. Just to give an idea of the scope of the problem, around 30% to maybe 33% of patients with epilepsy will develop intractability or drug-resistant epilepsy. So there's a pretty significant population of patients with epilepsy that we manage as a group at Nationwide Children's Hospital for intractable epilepsy. And by the time they're meeting any of us, Dr. Shakuni or myself in clinic, or we're discussing them at conference, typically they will have already had the diagnosis of intractable epilepsy. And so we would consider them candidates for surgery based upon our discussion. So there are different types of epilepsy surgery. Just to kind of familiarize everyone with the nomenclature, a stage 1 epilepsy surgery is to allow for invasive monitoring, which means monitoring below the level of the scalp, like intracranial monitoring. Potentially curative surgical options would include a lesional resection. A lesion is just an abnormality on an imaging study, which is often correlated or associated with seizure activity. So a lesional resection can be either done as just a single, one-time surgery, or it can be done as a second stage operation after invasive monitoring, which would have been allowed, which would have been fostered by the stage 1 surgery. Other types of potentially curative surgeries are lobectomies, which is where you're actually removing a large portion or even a full extent of a cerebral lobe. There's the frontal lobe, temporal lobe, parietal lobe, occipital lobe. The temporal lobectomy is a very common operation performed, especially in the adult population of medically intractable epilepsy. And then more extensive operations, which we primarily see in the pediatric population, especially the younger pediatric population, would be a functional hemispherotomy, where you're functionally disconnecting an aberrant hemisphere from the remaining or quote good hemisphere, or an anatomic hemisterectomy, which is where you're physically removing nearly all of the abnormal hemisphere. Obviously, these are very invasive operations. The indications are very specific and very narrow, but typically those are reserved for patients who have intractable epilepsy due to an aberrant hemisphere. And that can be from a perinatal stroke or a hemorrhage or a significant traumatic brain injury. It can be from Rasmussen encephalitis. It can be from a diffuse cortical dysplasia or Sturge-Weber syndrome. So there are a variety of diagnoses, or like hemimegalencephaly. There are a variety of diagnoses that can lead to consideration of that type of hemispheric surgery. Traditional palliative surgeries would include corpus callosotomy, where you are disconnecting the main white matter fiber tract that connects the two hemispheres, or a vagus nerve stimulator insertion, which is like an open loop stimulation of the vagus nerve, which has been used for many years and reported in the literature extensively. Techniques of neuromodulation include responsive neurostimulator, RNS, which is gaining a lot of popularity recently, deep brain stimulation, DBS, which is also gaining in popularity. The DBS has been primarily used before for movement disorders, but now, different findings about thalamocortical connectivity has ushered in a wave of treatment with DBS. And then, as I mentioned, as a palliative procedure, vagus nerve stimulation as well. So minimally invasive techniques, primarily minimally invasive techniques for invasive monitoring primarily involve stereotactic electroencephalography, or stereotactic EEG. And that's commonly performed by robotic stereotactic assistance, ROSA. Now, I put the picture of the modality that we use, but that certainly is not the only modality. There are two main modalities currently, with others I think forthcoming. But stereotactic electroencephalography has really increased in popularity and really dominates the landscape of invasive monitoring, and which is a new development really over kind of like the past 2 decades. And then another minimally invasive technique, which is ushered in a new type of treatment paradigm, is MRI-guided laser interstitial thermal therapy, or MRIG-LIT for short, or also called stereotactic laser ablation. Okay, and so these are just some representative pictures of the robotic stereotactic assistance platform that we use at Nationwide Children's Hospital, and then some intraoperative images of what an ablation zone may look like. This is for a stereotactic laser amygdalo-hippocampotomy, where we're targeting the mesial temporal structures, which is a very common procedure performed in the adult population especially. So the traditional technique of invasive monitoring, and really performed up until recently, when stereotactic EEG became much more popular. The traditional technique involved a large craniotomy for placement of a subdural grid and strips, okay, and occasional depth electrodes. This technique involved like large scalp incisions, a wide craniotomy, and dural exposures, and really extensive dural openings. So the dura is the covering of the brain. So you really are exposing a lot of cerebral cortical surface. And this technique really optimizes cortical surface and basal surface, like the surface on the base of the brain, coverage, with grids. But there are a lot of limitations for deep targets and bilateral coverage. Deep targets because surface grids can only be glided along the base of the brain to reach certain unvisualized targets, but deep targets within the parenchyma have to be accessed by something which actually violates the tissue barrier. And then bilateral coverage, you can imagine, is a limitation because that's a pretty large operation to do bilateral craniotomies, but we have performed that before. And there's significant challenges with repeat and revision surgery because of scarring between the surface of the brain and the covering of the brain, the dura. And that can result in really prolonged operative times and even risks for neurological impairment just because of abrasions to the cortical surface and venous congestion, just because some of those veins may have to get cauterized as they are lifted up from the dura. Lifted up with the dura. And then there are risks of morbidity related to the mass effect from the actual grid. But again, it was the primary modality of invasive monitoring until recently. We still use it in rare circumstances, but I would say that while it dominated the landscape of invasive monitoring, really when I was in fellowship or residency, to the point now, which just 6 or 7 years later, I would say the majority of academic neurosurgery, like epilepsy surgery groups, are using stereotactic EEG for the overwhelming majority, maybe 95% or more, 99% or more of their invasive monitoring cases. So these are some pictures of the way kind of it used to be done, or still is done maybe in a few centers, of traditional techniques of craniotomy for subdural grid and electrode insertion. So you can see here a large dural opening, a pretty large extensive cortical surface exposure, and then placement of a grid which lies on the cortical surface. And you have to secure them in place. You can see these little sutures here. You can suture the grids to each other, and then you eventually suture the grids to portions of the dura so they stay in place. And then one technique that we learned, rather than trying to close the dura, which is the natural covering of the brain, to itself over the grids, which may result in some mass effect as you get it tighter, we incorporated some dural grafts, and we would do something called an expansive duroplasty, just to basically give everything more room. And we thought that was a really good technique for safety. These are some examples of imaging after the traditional invasive monitoring, where you can see this is a head CT. Where you can see the artifact from the electrode contacts, and these are axial, coronal, and sagittal views. This is actually just like the X-ray component of the CT scan, like a localizing film. So some of the problems associated with this larger exposure and this larger craniotomy would include an intracranial hemorrhage, and the rates varied in the reported literature, about 0 to 16%. Not always clinically meaningful or clinically symptomatic, but still something that would have to be watched closely. Up to 3% of patients can experience mass effect and transient neurological deficits just from the grids, and that can also be related to some venous engorgement or venous obstruction, because you have these grids on the surface of the cortex, and some of the veins that are also on the surface of the cortex may actually get compressed by the grids. Risks of CSF leakage are about 1 to 3%, so pretty low, but significant if it happens, because there's an elevated risk of infection, which has been reported up to 1 to 16% of the time. And then patient discomfort. Patients just don't tolerate this operation as well as the minimally invasive approaches, which is something that we've found with more experience with stereotactic EEG. Patients can have decreased alertness and interaction. They can develop atypical seizure activity because of the mass effect from the grids. And then overall, they just don't, they don't really have a really great benign appearance while we're watching them, after this type of surgery. Oftentimes they're just very uncomfortable and, having a lot of vomiting and headaches. Unfortunately, unsuccessful invasive monitoring, like where there's a lack of seizures, can occur up to 5% of the time, or inability to localize a specific region of onset can occur up to 10 to 20% of the time, depending upon which studies you believe. Given these, given these difficulties with, invasive monitoring involving craniotomies, stereotactic electroencephalography or SEEG with robotic stereotactic assistance was developed, really primarily a France-based technology, and something, stereotactic EEG is a technique that is really been explored more significantly and developed in Europe, and then really, kind of came to the United States secondarily, but has really been increasing in popularity. Robotic stereotactic assistance fosters a very efficient, iterative and accurate insertion of these depth electrodes. And so basically, in comparison to the large, scalp incision and large craniotomy for a subdural grid, stereotactic EEG depth electrode insertion involves just a small scalp incision at each site. You can target both superficial as well as deep locations, and you can really achieve wide coverage without necessitating a greater exposure. So you can cover multiple cerebral territories just by multiple different depth electrode leads, rather than with a grid, you have to just increase the size of your scalp incision, craniotomy, and exposure to allow for coverage of multiple cerebral territories. You can also cover bilateral territories in a relatively straightforward fashion with stereotactic EEG. And you can also test multiple hypotheses, and those hypotheses might not necessarily be connected, anatomically in close proximity. And so if an individual has different seizure types or different imaging, or different imaging findings that don't necessarily coalesce into one unified hypothesis, but in fact suggest 2 or 3 different potential areas of seizure onset, you can test those very readily with stereotactic EEG, whereas with the craniotomy for subdural grid, it may be very challenging. And this is always just a very interesting fact that I like to point out. From the literature, that about 60 to 70% of the cerebral cortex lies below the surface. So you can imagine how limiting it is to just do subdural grid coverage, and how much of the deep deep cerebral cortical territory you're missing without doing this style of investigation. And it's really just this very complex infolding within the sulci. You would miss all of these territories within the folds if you were just sticking to surface grids. So the changing paradigm of stereotactic electroencephalography in comparison to the craniotomy for subdural grid insertion has required a different understanding of epilepsy, and that's really using network theory. It requires more preoperative planning, including hypothesis generation, really close detailed study of seizure semiologies, brain MRIs, PET scans, et cetera. And then it requires a lot of time to plan appropriate trajectories. And so, the neurology team and the neurosurgery team, after we discuss these patients and identify them as an appropriate candidate for surgery, and specifically, a further, a surgery which allows for further identification and localization of a potential, epileptogenic zone. The neurology team typically sits down and reviews all the seizure semiology and imaging data to come up with potential targets. And then either the neurology team, kind of takes a first, takes a first step, or the teams do it together, or the neurosurgery team does it. Kind of depends upon the institution, but there has to be a lot of time devoted to planning all these different trajectories and, surface targets and deep targets, et cetera. So, now, despite the fact that there's probably more preoperative investment of time and planning for the surgery than the prior traditional, approach, which is craniotomy and subdural grid, the new technique typically reduces intraoperative time. Okay. So this is just an example of a schematic of the cerebral cortex, kind of viewed laterally. And, this is what one of the planning sessions might look like. You choose different categories based upon the patient's seizure semiology and imaging findings. So here, you can see that there are some temporal lobe targets, there are some frontal lobe targets, there's even a parietal lobe target, which is really just a continuation of this portion of the temporal lobe. And so, you could tell there was high suspicion for a frontotemporal epileptogenic network in this individual. And some of these targets, some of these trajectories extend deeper to more medial targets here. And so this is just an example of what one of our, planning schematics might look like. And then post-operatively, this is an example of imaging after depth electrode placement. Here is just an X-ray. We typically perform a brain MRI after the placement of these depth electrodes to kind of have our gold standard imaging to localize exactly where these depth electrodes are, so that if any of them are, reflect abnormal between seizure activity, interictal activity, or ictal activity, we can, appropriately identify those neuroanatomic regions and potentially plan for them to be involved in the next step or the treatment phase of surgery. Okay, and that kind of brings us to the results of invasive monitoring. So invasive monitoring, or we call it phase 2 monitoring, can last for variable durations of time. At our institution, we typically plan for the norm is about 6 or 7 days, so about a week of phase 2 monitoring, and then the depth electrode leads can be removed, but sometimes shorter durations for young kids who have a significantly high seizure burden. Sometimes their seizure frequency allows for a shorter monitoring period. Or unfortunately, sometimes patients do not have their typical habitual seizures in that 1 week, and so we extend the monitoring time, and that can extend up to 3 weeks. And we've even had one girl who was a trooper and actually went through monitoring for 4 weeks. She just does not have highly frequent seizures, and we were not able to capture her typical habitual seizures over an extended duration of time. But anyway, after that phase 2 monitoring time, if there's observation of adequate typical or habitual seizures, that data and then stimulation, where you actually stimulate the electrodes to define eloquent cortex and see if you can provoke any habitual seizures. All of that data is combined with the preoperative data, which we call phase 1 monitoring, and that's used to develop a treatment plan. And that treatment plan can include a resection. So there's a second stage or stage 2 lesion resection if there's a clearly identified abnormality on imaging, an anatomic resection. So maybe the entire temporal lobe was abnormal, or the parietal lobe or the frontal lobe is abnormal, and so we can give consideration to removal of that lobe or a portion of it. Okay. If there's a smaller, well-defined area of epileptogenic onset, that could potentially be approached with another minimally invasive technique, which I'll talk about in a second, which is stereotactic laser ablation, or MRI-guided laser interstitial thermal therapy, MRI-GLIT. That's kind of on one end of the spectrum, and then on the other end of the spectrum, what if the entire hemisphere is abnormal, and there are abnormal discharges diffusely from an aberrant hemisphere? So a functional hemisterotomy or an anatomic hemisterectomy could be recommended. Most institutions, especially in the past, in the recent years, would prioritize a functional hemisterotomy over an anatomic hemisterectomy. That's kind of out of the confines of this talk, but just so you know. And then, unfortunately, if there is not a well-defined focus that can be removed safely, we then start considering either palliative surgery or neuromodulation. Okay. There's a different timing scheme for the second stage surgery. So typically when we would do a traditional craniotomy with subdural grid placement, when we take them back to the operating room for grid removal, we actually do the resection at that time. But in this case, because these are just really small incisions, and it would be a much different approach for the actual treatment phase, we typically remove the stereotactic EEG depth electrodes. In kids, in children, we take them to the operating room to remove it. But in adults, sometimes they're just removed at the bedside. And then we typically wait around 6 weeks. Every institution is a little bit different, but most epilepsy surgery colleagues I've spoken with, and our practice paradigm is to typically wait about greater than or equal to 6 weeks following depth electrode removal to try to decrease any risks of infection, because these were indwelling depth electrode leads for however long of time. So we discussed some of the complications related to the craniotomy with subdural grids. Now, this is a minimally invasive technique, but there's still risks and there's still complications. So one of the larger series reported the accuracy or I guess the inaccuracy rates of depth electrode. And they found that the median entry point error was about 1.2 millimeters. And then the median target point error. So again, entry site is like kind of like a superficial location of where the depth electrode is entering. And then the target is the deep target. The median target error point error estimate of about 1.7 millimeters. And then only about 1 to 2% of entry and target points were greater than 5 millimeters. Okay, so pretty low rate of having like a significant deviation from the planned trajectory. Intracranial hemorrhage can occur in about 4% of patients, especially frontal and parietal entry points. Fortunately, it is often extradural, meaning outside the covering of the brain, and not necessarily in the brain itself, but obviously a hemorrhage can occur along the tract. We spend a lot of time planning these trajectories to avoid any vessels along the surface or deep within the brain. But sometimes it's, you can't see every little minor vessel, especially if they're below the resolution of the MRI. And then sometimes things just kind of happen in the operating room where there may be just a slight, even few degree deviation from your planned trajectory, and that could potentially result in a hemorrhage. But most of the time, actually, the hemorrhage usually comes from the dura. And it ends up being between the dura and the bone, or the bone itself, because the bone is so vascular and it's such a small opening that you actually can't, cauterize anything. So CSF leakage, is a theoretical risk. Fortunately, it doesn't really happen too often with stereotactic EEG. And then similar to the craniotomy with subdural grid, you can have unsuccessful invasive monitoring where the patient doesn't have seizures, or they have atypical seizures, or you may have inability to localize the seizure onset. And then, or need for additional coverage. So sometimes, we may have to take a patient back to the operating room to insert more depth electrode leads based upon the phase 2 monitoring that we have. So then one of the outcomes of phase 2 monitoring is laser ablation. So this is another minimally invasive technique, and that's why I'm gonna focus on this as part of the treatment regimen for intractable epilepsy. Stereotactic laser ablation, or MRIG lit, is a technique that had its beginnings with radio frequency ablation, or RFA, but there were some safety concerns and there were some limitations in RFA. Especially not being able to watch it in real time. And the stereotactic laser ablation, or MRIG lit technology was developed as an enhancement of those earlier techniques. And this, it allows for a safer strategy of performing an ablation using real-time imaging, so MR thermography. Okay, so it involves basically interstitial, meaning like within the tissue, placement of a cooling cannula. So basically just a long, thin cylinder that houses a laser fiber. Okay, and oftentimes this cannula is placed using robotic stereotactic assistance to enhance accuracy. And you basically insert this cannula with an indwelling laser fiber to a target focus of seizure onset. Or as for a palliative procedure, you can actually target a mode of propagation or seizure generalization, which would be the corpus callosum. And then using the laser therapy and then real-time imaging, what we call a magnetic resonance thermography, or MR thermography, you can actually watch an ablation being performed, and then there's an equation, the Arrhenius equation, which relates a temperature and duration of time of the laser activity to estimate an ablation zone. So stereotactic laser ablation has indications outside of epilepsy. It is used occasionally in neuro-oncology. We're going to focus on its uses in epilepsy surgery. The typical indications include mesial temporal sclerosis, or MTS, which is a common diagnosis especially in the adult population. And the technique performed for that is stereotactic laser amygdalohippocampotomy. And then for small or moderate sized regions of epileptogenic onset, you can consider stereotactic laser ablation. And that would include like a focal cortical dysplasia, a cortical tuber, as with tuberous sclerosis, or even encephalomalacia, from like a prior cerebral infarct. And then one of the newer applications of stereotactic laser ablation includes a disconnected repalliative procedure, which is corpus callosotomy. So a stereotactic laser ablation corpus callosotomy, which is, a technique that our institution has really, been, gaining favor with, and we've been offering it to a lot of families who are, very amenable and very interested in this technique. So here's an example of a stereotactic laser ablation for mesial temporal sclerosis. We would call it a stereotactic laser amygdalo-hippocampotomy. So again, insertion of a long cannula, okay, through the cerebral cortex down to a target, okay, and that target is typically the region of epileptogenic onset. Okay, for these, for these types of procedures. And then after confirming appropriate placement, you can then start performing the ablation. And I didn't include any, images of the ablation as it's being performed, but basically you use thermal maps to watch the temperature of the ablation zone, and then watch the temperature of surrounding structures to protect them, such that if the temperature of any of these surrounding structures elevates beyond a threshold that you determine, the ablation will just terminate, will just cut off. And so then you have to let it, cool down. And then you just, you basically try to modify the parameters of ablation to not put surrounding structures at risk. Okay. So this is just a picture of some of the signal abnormalities you can get after performing a laser ablation, specifically a stereotactic laser amygdalo-hippocampotomy. Here's another example, a cortical tuber in a tuberous sclerosis patient. Obviously these patients unfortunately have many cortical tubers, but with stereotactic electroencephalography, you can monitor and investigate multiple of these tubers. And we found that this specific cortical tuber was the primary seizure driver. Okay, and so after evaluating the phase 2 monitoring data and identifying this particular cortical tuber as the culprit for epileptogenic onset, we then decided to offer the stereotactic laser ablation. Largely also because that patient had a contralateral craniotomy with a tuber resection in their past before laser ablation really was offered at this institution, or even in general. We thought it's very reasonable to offer them a more minimally invasive approach as opposed to just another large craniotomy on the other side. So you can see here, these are some of the trajectories for placement of the cooling cannulas, which would house the laser fibers. And this is an imaging study, like a T2 MRI, which shows the stereotactic laser ablation of that cortical tuber. And here is actually another indication, a less common indication for stereotactic laser ablation, but it's an area of encephalomalacia from a prior cerebral infarct. And this patient actually had multiple areas of cerebral infarct, but she's highly functioning, and we didn't think it was appropriate to consider a functional, hemispherotomy or a very large resection on her because she's so highly functioning at baseline, but she does have intractable epilepsy. And so we did stereotactic electroencephalography, and our monitoring showed that while there is, some abnormality to this network here, really the primary driver of seizure activity was located in a more anterior area of encephalomalacia. So I didn't include the pictures of the pre-op, but this is what the post-operative ablation looks like. It's a pretty extensive area, required a lot of trajectories. I think we used like 7 or 8 trajectories, which you could consider to be cost prohibitive, but because the company that we used knew that we were using so many trajectories, they were able to basically work out a compromise where we could not have to cost the hospital such an exorbitant fee, but this is a reasonable option to consider to avoid having to do like a large craniotomy with resection. Unfortunately, knock on wood, this patient has been doing very well in terms of her seizure activity with a very significant favorable response after the laser ablation. So another kind of newer indication for laser ablation includes like a palliative or disconnective procedure. And it's been applied recently for corpus callosotomy. Now, corpus callosotomy is division or dissection of the main white matter tract that connects the two cerebral hemispheres. And so the corpus callosum is pictured right here. This is just a sagittal MRI. The indications are most commonly for drop attacks or generalized tonic-clonic seizures, where there's very rapid propagation between the two hemispheres of abnormal discharges. And so this type of operation was performed for many years as an open surgical approach where the surgery team would have to access the space in between the two hemispheres called the interhemispheric fissure, and then continue to work more deeply to get down to the level of the corpus callosum, and then using the operative microscope and then small dissecting instruments dissect and divide basically these white matter fibers in the midline. And as you can imagine, it's an invasive surgery, and it involves typical risks of open surgery and a fair number of morbidities. So individuals have started applying laser ablation to corpus callosotomy, and we've, our group has really, demonstrated a lot of interest in this technique, and I personally have a lot of interest in this technique. Typically, I use 4 trajectories if we're going to do the complete laser ablation corpus callosotomy, and this is just an example of how one might use 4 different trajectories to model the curvature of the corpus callosum. And so this is what it looks like intraoperatively. These are just actual alignment rods, which are for testing and making sure the accuracy is okay. And so after we place these little anchor bolts which drill which go through the scalp and drill into the skull, and again this is all performed using robotic stereotactic assistance. These alignment rods are placed so that we can perform an intraoperative CT scan to see how accurate we are in comparison to what we planned preoperatively. And as long as the accuracy is appropriate and adequate, we then proceed with insertion of these cooling cannulas, and again, these house the laser fibers. So these are just examples of, the laser cooling cannulas inside the corpus callosum where we are about to, perform an ablation. So you can see how all of the sites of the corpus callosum are basically covered with these 4 trajectories. And so then we perform the ablation, and then you can see these T2 signal changes here along the corpus callosum. Occasionally we do get spread outside the corpus callosum, but usually, fortunately it's clinically silent. And then you can see here other examples. This is just kind of imaging artifact. There was some warping around the cannula, but basically you can see here a pretty extensive coverage of the laser ablation throughout the extent of the corpus callosum. So there's limited published data, and what I'm presenting is mostly in pediatrics, just because that's the literature and the outcomes I'm more familiar with. But most of the data is limited to single institution case series, and in those children with lesional, meaning like they have an abnormality on MRI, lesional drug-resistant epilepsy, where there's that epileptogenic focus has been, confirmed with concordant data to be located at the lesion. There's a pretty reasonable outcomes. Engel class 1 or 2, those are standardized outcomes that we use for seizure activity following surgery. And that's basically Engel class 1 is essentially seizure freedom. Class 2 is basically near seizure freedom, but maybe just occasional seizures because of with weaning or withdrawing a medication. And that's about a 41 to maybe close to 50% rate of success, Engel class 1 or class 2, using laser ablation. And then, kind of more commonly reported in the adult literature, stereotactic laser ablation for mesial temporal lobe epilepsy has about a 50 to 60% rate of seizure freedom overall. And then if you look particularly at those subjects who have mesial temporal sclerosis, meaning imaging abnormalities of those deep mesial temporal structures, the rate does increase to about 56 to 73%. That's a range of reported success rates in the literature. So, kind of transitioning to more neuromodulation techniques. So those were ablation techniques, which are potentially curative. Okay. Now, in certain individuals, there may not be a target that you can resect or remove or perform an ablation on because of its eloquent nature. Or there is not one specific target that you can focus upon for a treatment. So in that setting, neuromodulation is an option. You still have to have, you typically have to have adequate phase 2 monitoring data that justifies your selection of targets for neuromodulation. So the primary modes of neuromodulation we'll discuss are responsive neurostimulator, RNS, and then deep brain stimulation, DBS. But it's important to not forget about vagus nerve stimulation. I mean, this is still an important modality that we use in epilepsy surgery, especially, for patients who we've kind of eliminated or excluded any intracranial surgery options, or with patients' families who are not comfortable with cranial surgery. For the appropriate patients, we would certainly offer vagus nerve stimulation. In contrast to these types of neuromodulation, RNS and DBS, vagus nerve stimulation is more of an open loop stimulation, meaning there's no direct feedback that the device gets to modify its activity. Reported rates are variable. There's, for focal seizures, the mean or average focal seizure frequency reduction about 25 to 28% early after a vagus nerve stimulator insertion, with an improved effect later. So about 1 year to 3 years out, you can get median seizure reductions of about 35% or even mid 40% up to 3 years. So there is pretty well documented proof and experience of improving seizure control with time duration with VNS, which is an interesting concept in medicine, because usually with medications, tolerance develops, whether it be for anti-seizure medications or cardiac medications or blood hypertensive medications. There's typically tolerance with medications or psychiatric medications, but in this situation, there's actually an improved effect over time. And then one of the better reported studies is a meta-analysis, which looks at the extent of literature that's been published on a particular question or topic. And this meta-analysis was comparing the vagus nerve stimulator to corpus callosotomy, and it basically reported rates of greater than 50% seizure reduction in about 1/3 to 2/3 of patients who had a VNS placed. It's highly dependent upon seizure type. Okay, like tonic seizures, myoclonic seizures, generalized tonic-clonic seizures, atonic, drop seizures, etc. And then even greater, greater results, like greater than 75% seizure reduction in a smaller percentage, but about 20 to 40% of patients experience that. And again, heavily dependent upon seizure type. And there were others, there were smaller percentages of patients who were seizure-free as well. So for neuromodulation, we'll first discuss responsive the responsive neurostimulator, or RNS, which is as the name suggests, it's a responsive form of stimulations. It's a closed loop, meaning that the device can receive information and then can modify or distort the electrical activity of its target, and there's a feedback loop. So it involves responsive or closed loop focal stimulation of an epileptogenic zone or a focus, or propagation pathways, meaning where which pathways the seizures are spreading by. And basically, the device recognizes abnormal electrographic activity or epileptiform activity as it is, programmed and recognized by a neurologist, who reviews the the electrophysiologic data and helps, modify the programming of the RNS. And then basically when it recognizes what's been deemed as an abnormal, electrographic or epileptiform activity, it delivers a brief stimulus to neutralize or basically disrupt the epileptiform activity. And the neurologist is very involved with reviewing the data from RNS, and they may adjust detection and stimulation parameters based upon how the patient's doing clinically. And the typical indications for RNS are intractable epilepsy or drug-resistant epilepsy with frequent disabling focal onset seizures. It's not typically recommended for patients who are only having maybe 1 to 2 seizures a month because it may be difficult to get adequate data and really gauge outcomes. But also importantly, there have to be right now less than or equal to 2 epileptogenic foci, which have been localized by diagnostic testing, like specifically invasive monitoring. That might increase in the future as RNS may have greater ability or a greater number of leads that can be connected to the actual generator. So the RNS components include a casing or a ferrule, which actually basically sits into the skull. We typically do a craniectomy, like remove a portion of the skull to allow it to sit in. And then this cranially implanted stimulator, which is, programmable. And then to access the targets within the brain, we can either put in depth electrode leads or small cortical strip leads that can go directly on the surface of the brain. We typically insert 2, but it can be up to 4. Currently, the generator only has 2 ports, and so if we insert 4, 2 of them just have to be just placed, and their leads won't actually be connected, but they can be nearby in case during a revision surgery you want to switch out, the leads which are connected and the leads which are not connected. And typically you target 1 to 2 seizure foci, and then each of these lead contains 4 electrode contacts. So here's a picture of the planning of it. These cases take a lot of important considerations of where you want to put the scalp incision. You want to minimize any risk for wound breakdown, which is one of the main risks of surgery. So, one of the recommendations we got from institution that I trained at for residency that had a lot of experience with RNS is to do these cases with plastic surgery up front. And so that's our paradigm. And so, we plan the incision together. We figure out, what's the best placement of the RNS generator to allow for revisions in the future. We don't necessarily have to open up the entire incision. We can just open up a portion of it to change out the generator. So here's a pretty standard style of insertion, the planning with the incision. And then here's an example of the incision being opened up, and then we do a craniectomy, meaning removal of the bone, okay, so that we can place the generator inside. You can imagine that putting the generator on top of the skull would be a little bit too bulky, and the scalp on top of it would be at risk for breaking down, and this could erode through the skin. So we really want to avoid that. Here you can see there's one depth electrode lead going into the skull. We drilled a small hole and we place this again using robotic stereotactic assistance. And then its tail, we just had it go underneath the generator for a short distance, or just to kind of minimize what's outside the skull, and then we have it pop back out here, and then it'll be connected to this, to these ports. We do these cases with our plastic surgery team, which does a great job of elevating an additional layer of tissue to cover the battery. Okay, we call that's pericranium, and it provides for really good coverage over the device hardware. And then this is what it looks like post-operatively. This is a lateral projection of a skull X-ray. This is a head CT, a coronal view, where you can see the responsive neurostimulator generator, okay, within the bone. And then basically here's one of the depth electrode leads, and here's some other pictures of depth electrode leads which are placed inside. So some of the downsides or risks and disadvantages of RNS, as I mentioned, wound infection or wound dehiscence is a major concern. Scalp erosion or hardware and device exposure, which basically indicates a high, the presence of or high risk for infection. And then, there are repeat surgeries which are needed to exchange the RNS generator or the depth electrodes if that is required. And then, as with any treatment for epilepsy, some of the, risks could be inadequate seizure reduction. But also there's a lot more responsibility placed on the patient required, at least initially, because they have to consistently download their information from the RNS, so that the neurologist will be able to evaluate it and, to determine, how many seizures they're having and just the abnormal activity, which they can, use to help program the device. So some of the published outcomes, again, it's early in terms of the experience with RNS, and this is primarily adult data, but some of the published outcomes are an overall seizure frequency reduction of about 40% over the short term, about 3 months, and then longer term outcomes like 1 year and 2 year, you can get a median seizure reduction of 40%. And 53%, based upon published studies. And then a even further out 3 to 6 years, a median seizure reduction of 48% to 60%. So about half to 2/3 of seizure reduction. Now, a responder rate, meaning those individuals who had greater than equal to 50% seizure reduction at 1 to 2 years, you can see that positive response rate in about up around 50% of patients, and then even up to 60% of patients at 3 to 6 years. So again, there's this concept of improving outcomes with greater duration of time. And then, looking at the opportunity to achieve seizure freedom, for those individuals, for those individuals who had an RNS placed, the percentage of those who had at least one seizure-free period for at least 6 months was 23%. So that's not bad, almost a quarter of patients. And then about, maybe about half that, or a little bit more, 13% had at least one seizure-free period of greater than equal to 12 months. So there is certainly the opportunity to achieve seizure freedom with these neuromodulatory devices. So some of the published complications and adverse events would include, as I mentioned before, implant site infection or soft tissue breakdown, which is about 2.5% to 9%, and then surgery for RNS explantation, meaning removal of it, about 5%, and then evidence of an intracranial hemorrhage would be about 5%. So similar to what we see with stereotactic EEG. So. Another type of neuromodulation technique is deep brain stimulation, DBS. Again, primary experience with DBS has come primarily from movement disorders, but it has been applied more recently to intractable epilepsy, and that mainly because of recognition of thalamocortical networks. So DBS involves deep brain stimulation. It's stimulation of thalamic targets, and again, it's utilizing our known information about thalamocortical networks and basically stimulation of these to neutralize or disrupt a seizure propagation. The differences from neuromodulation with RNS is that DBS doesn't always require localization of an epileptogenic, or doesn't require at all really localization of the epileptogenic focus, because you're leveraging the thalamocortical networks, not necessarily its particular area of onset, because the targets for DBS are the same no matter where that potential focus may lie. The additional benefit of DBS, it may be effective for multifocal or generalized epilepsy as opposed to RNS, which is really for focal epilepsy with less than or equal to 2 defined epileptogenic foci. So the typical targets for DBS, typical targets of DBS for intractable epilepsy or drug-resistant epilepsy are the anterior nucleus of the thalamus, the ANT, or the centromedian nucleus of the thalamus, the CMN. So these are the 2 targets that have been used most frequently and reported most frequently in the literature. The typical targets of the target of anterior nucleus of the thalamus for DBS typically tries to target seizures which have a which have a concern for frontal or temporal epileptogenic networks. And I mean, probably out of the scope of this lecture, but there's an important neuroanatomic circuit, which is called the circuit of Papes or Pepez, which has important roles in emotion, learning, and limbic seizures, which would incorporate any of these anatomic structures you see here: the hippocampus, the fornix, mammillary bodies, etc. But again, mainly frontal and temporal epileptogenic networks seem to be the most appropriate applications of the of DBS placement for within the anterior nucleus of the thalamus. Now, on the other hand, DBS targeting the centromedian nucleus of the thalamus is likely more effective for generalized seizures. So, frontal and temporal epileptogenic networks, you would more strongly consider anterior nucleus of the thalamus as a target for DBS. But for generalized seizures, there's literature data that suggests the centromedian nucleus of the thalamus would be a more appropriate target. And that's mainly because it has very strong connections to the basal ganglia, so it can access a very wide aspect, a very wide distribution of the cortex, and it also has strong connections to the hippocampus. So again, it may be more active. The centromedian nucleus of the thalamus, in particular, may be more active with generalized epilepsy, and so therefore that nucleus of the thalamus is a better target for generalized seizures. Some of the outcomes for DBS, most of them are based upon the Sante trial. So targeting the anterior nucleus of the thalamus, DBS has provided for a median focal seizure reductions of about 40 to 50, 55% at about 13 months, and then 26 months, so about 1 year and 2 years. So pretty reasonable outcomes. And then median seizure reduction rates of 40% to 60%, even up to 70%, close to 70%, again, with increasing time intervals, early 3 to 4 months, and then 3 years, and then 5 years, respectively. And for generalized seizures in Lennox-Gastaut syndrome, targeting the CMN, the centromedian nucleus, again, which is presumed to be more effective for generalized seizures, had a median seizure reduction of 80% over 19 months. So there's pretty encouraging rates there. So some of the complications and risks for DBS include just implant site pain and paresthesias. Paresthesias are just like abnormal, like pins and needle sensations, or just abnormal sensations, about 10 to 18%. Sometimes the settings have to be modified to limit those symptoms. Sometimes patients, unfortunately, the implant site infection still occurs, as with RNS, and then any necessity for lead revision can occur in up to 8%. And then, based upon how strong the stimulation is in the thalamus, sensory disturbances can be, an impactful issue for patients. And again, sometimes sometimes the settings of the RNS can be modified. And I misspoke when I said for implant site pain and paresthesias, the RNS settings wouldn't be modified for that. I misspoke. The implant site pain and paresthesias is mostly just related to the scalp incision and the underlying hardware. But sensory disturbances, in the contralateral aspect of the body, or just in general, can be, impactful or debilitating enough to require setting modifications. And then incidental intracranial hemorrhage, again, similar to the rates that have been published before for RNS and stereotactic EEG, about 4%. So, I think one of the main points that I wanted to communicate about these minimally invasive techniques is that it's offered broader applications and broader indications for epilepsy patients. So these minimally invasive techniques and strategies of neuromodulation have really expanded our indications for epilepsy surgery. So some patients that were previously relegated to like the non-operative pool, or those who are automatically guided towards VNS, now may be candidates for intracranial surgery, which may offer elevated rates of seizure reduction or even potential for seizure freedom. It allows us to access and target eloquent areas of epileptogenic onset, which in the past have been, kind of off limits in terms of treatment. In individuals who have had prior epilepsy surgery, revision surgery can be very challenging with significant morbidity and significant risks. And stereotactic EEG and MRI guided laser interstitial thermal therapy offer minimally invasive techniques that reduce the morbidity of the exposure in those individuals who may have significant scarring between the covering of the brain and the cortical surface. So this offers a whole new diagnostic and treatment opportunity for these patients. And then patients with generalized seizures with a very prominent thalamocortical involvement. In the past, those individuals may not have been considered for surgery at all, or maybe would be considered for VNS insertion, which is still a very legitimate therapy. But in this instance, there's a chance for offering them a kind of more direct mode of treatment with neuromodulation that may offer elevated rates of seizure reduction and great opportunities for seizure freedom. And then, as I mentioned in the last slide, in terms of outcomes, generalized seizures in Lennox-Gastaut syndromes, including severe generalized tonic-clonic seizures, those individuals may be candidates for laser ablation corpus callosotomy, especially if they were to have drop attacks. But these minimally invasive techniques, including laser ablation and neuromodulation, really offer more treatment options for those individuals with intractable epilepsy. So, I really appreciate your time. And again, I think all of the speakers on the panel would prefer this to be in person, but given the circumstances, it still is great to, at least, share with you all our perspectives on epilepsy surgery, even in a virtual format. So, I definitely hope you enjoyed the presentation, and happy to take any questions or comments. And there's my contact information as well. So thank you very much.